I feel terrible chills, nausea, and my whole body aches. I stopped using heroin 2 days ago. Mr. David, 36-year-old construction worker male, marital status single, presented to the clinic reporting abrupt cessation of heroin use 48 hours ago after several months of daily use. Patient also reports symptoms of yawning, lacrimation, rhinorrhea, muscle aches, chills, diarrhea, nausea, and anxiety. He admits to using 12 bags of heroin daily via intranasal route for the first year. No history of overdose or IV drug use, no suicidal ideation reported. There is history of depression, which was untreated, multiple prior attempts to quit opioids, all unsuccessful. Family history, father had alcohol use disorder, no family history of mood or psychotic disorders. On physical examination, vitals, blood pressure 140 over 90, heart rate 98, temperature 99.1 degree Fahrenheit. Findings, dilated pupils, diaphoresis, piloerection, abdominal cramping. On mental status examination, appearance disheveled, appears anxious and restless, miserable mood, anxious affect, speech coherent, thought process logical, thought content no hallucination or delusions, fair insight, limited judgment. So this patient is suffering from acute opioid withdrawal syndrome. Per DSM-5 criteria, patient meets the criteria for opioid withdrawal syndromes. Recent cessation of opioid use after prolonged use and 3 or more withdrawal symptoms, nausea, insomnia, muscle aches. Let's talk about the management plan. Acute symptoms of management. Acute symptoms management. Let's start with clonidine 0.1 milligram per oral. Q68 hour. PRN for autonomic symptoms such as sweat, loperamide for diarrhea, hydroxyzine for anxiety and insomnia, acetaminophen or NSAIDs for muscle aches. Opioid replacement therapy, consider initiation of buprenorphine, naloxone, suboxone once moderate withdrawal is confirmed cause greater than 12. That's the scale for determining severity of opioid withdrawal. Psychosocial intervention, referral to addiction counselor and outpatient rehab program, encourage participation in narcotics anonymous or other peer support groups. Long-term plan, explore maintenance therapy options, methadone clinic versus office-based suboxone treatment, monitor for co-occurring depression, initiate SSRI after withdrawal resolves. Safety and monitoring, evaluate for suicidal ideation or high-risk behavior. Consider inpatient detox if home situation is unsafe or lack of support. Follow-up daily or every other day early in recovery phase, then weekly. Regular urine drug screens, then therapy, compliance monitoring.